There we go.
Okay. The Board of Direct Entry Midwifery will now exit executive session and reconvene open session at 8:41 a.m. No final decisions were made and no votes were taken in executive session. The public phone line has been unmuted and representatives of the news media may once again report all board discussions and actions. We are moving on to our reports.
Okay, I saw Sylvie pop on. If Sylvie's still there, does she want to do the director's report?
Can you hear me?
Yes.
All right, my camera is messed up, so I can't see myself, so it's hard to tell. I think it's time for a new camera. Director's report. Just a couple things. Most of you have heard, hopefully, that the indoor mask mandate is going to be lifted effective, supposedly, March 31st. The office still is going to be closed. They're hoping to open state offices in July. So hopefully it'll be sooner than that, but if not, we will continue as is until July. We're still open by appointment and appointment only. Other than that, we've got some staffing changes, nothing major that affects you, but lots of move around with staff. And mainly everybody's still working remotely, as you can tell by all of us having different backgrounds. Well, I guess you can't see me because my camera doesn't work, but any questions? No? All right. Let's go through the licensing and statistics. Has everybody had a chance to look at that stuff? Again, broken out by quarter, but this is licenses issued. Impressive. Quarter 2 of fiscal year 22, there's 7 licenses issued. That's impressive. Next slide shows licenses issued online versus paper. As those of you who've been around for a while, we know that you guys couldn't renew online in the past because paperwork had to be submitted. Once we changed those rules, everybody was able to renew online. And now you can see that more people renew online than they do through the snail mail. Next slide just shows broken out by age and gender. There's one unknown on there because you do not have to identify whether you're male or female. Next slide shows licenses by county. And you guys had asked for this, but this is their residence county. It's not necessarily where they work, but this is where their home, what county their home is in. Next slide just shows a long-term trend. So going up, which is fabulous. And then I'm on slide 29. So 29 is your financials. We can talk about this if you want. It's the same issues, same concerns, obviously more expenditures than revenues. And we continue to do as much as we can to try and, save on expenditures, but you can see there for the fiscal year 2020, there's more revenue brought in than expenditures. But then 2021, it obviously switches right back to the way it was. So any questions on that? I know that's the depressing slide, but no. Okay.
I know we've talked about this before. I guess I'm still not clear on why the expenditures are so high and so much higher on other years. And maybe it's like lack of experience, but I just don't get it. I don't understand. If someone knows and could explain, that would be great.
Yes. So the biggest factor on your guys' expenditures would be cases that go to all the way up to a hearing. If they go before an administrative law judge, even if the board prevails and the disciplinary action holds, we can only recoup up to $5,000 of those expenses. And so that's usually where the vast majority of, you'll have a big case, lots of expenses.
Got it.
And so for context, that's why we have the informal settlement process, correct? Is in part a cost saving measure.
Correct. So we implemented that to try and prevent, if possible, obviously sometimes it's warranted, but to try and prevent it from going all the way to a hearing and give the board an opportunity to maybe get into some sort of settlement agreement with the individual. All right, Bob, you want to go ahead? Does anybody have any more questions? I don't want to move forward if anybody else wants to talk about the financials.
I know that in the past we've had a more detailed breakdown of expenses, and I'm just wondering if I can request that for our next report. So Meredith
Sure.
and other new board members and the public can see sort of more details about the expenses.
Sure. So Nathan is logged in, listening to the board meeting. He's the one who gets these reports for us. So he'll make a note of that. So we'll make sure that we include this summary report and then a breakout of the expenditures. So the numbers that will align like with the 118,920, the 60,052, so that you can kind of see how that's broken out.
Okay. If there's no additional questions for Sylvie, I'll move on to the regulatory report. We've closed out 2017, 2019. We're working on 2021. We have 5 cases that remain open. And for the 2023, we have 3 that are open, giving us a total of 8 that we're currently working on.
Bob, why is it 2023?
Biennium.
Oh, got it. Thank you.
Almost had me for a second.
I knew there was a good reason. I just was curious. Thank you.
I would have blamed Nathan. He's the numbers guy. Any other questions for me? Okay. So next on the agenda are items for board action. Approval of administrative rule schedule. Sammy, are you still there? If
Yes,
you are,
I'm here.
there you go.
So before we do that, I provided the, what we call the parking lot list, that you guys have over time created and, put things on. I left it exactly how I had it, and it had been over a year since I had added anything to it. I did add some additional things, based on your previous meeting, but for you guys to go through, some of these things have been done, but I thought it best for you guys to decide if they need to be looked at or not, or we can just mark them off, but to determine which areas we're going to focus on, which will then help in turn decide the rulemaking, how to proceed with rulemaking, and then to go into some of the detail about House Bill 2993 and the racial equity and making sure that we are including all communities in our rulemaking. So I will leave it to you to determine which areas you want to focus on for rulemaking.
I know that one thing that I'm not sure is on this list, but was just really clarifying what we meant by non-reassuring fetal surveillance testing. And I don't know if we could do that by defining fetal surveillance. And open the definitions, or if we want to change that specific rule. It does seem like a lot of the things on this list we've already this round.
Some clarification that needed to be done around peer review and the group, not the group, the qualification review group and what that really means.
Yeah, the entity.
Entity, thank you. Those were the two newest ones. And those were the only two that really, the rest of them looked like we had done them all, but I thought I would leave them on there to make sure that I wasn't missing something.
Yeah, I would. Oh, go ahead, Meredith. Sorry.
I'm just wondering about this one that says risk out and transfers patient early before patient has complication. What is that? Does anybody remember what that was, when that was brought up? And I mean, I know there's a lot about transports in the new rules, but I don't remember this one.
I mean, I think it's pretty general. I don't know exactly when it was added to the list, but I think it was very well talked about at the last rulemaking, and to some degree, some of this was added into the last set of rules to make sure that you're assessing patients and things like that.
And that what we've talked about, like hoping that midwives recognize the pink flags before they're red flags. I mean, that sounds like what this is, but I wasn't sure.
Did you guys have other things that may not be on the list that we need to talk about or discuss? I mean, it doesn't have to be a rule change. Maybe it's something you just want to review in the rules, but it may not end up being a change.
Do we want to talk at all about VBAC and twins together? Like those are both initially talked about, but not when they occur at the same time. That's like adding a whole new thing, so that might not be appropriate here with what we're talking about, but.
This is Kelsey. Meredith, I think that we sort of address that in our how we talk about risk assessment of like midwives acknowledging cumulative risk. I have concerns around putting a rule like that into the rules because it's such a specific situation and just could lead down a rabbit hole of our rules being even more complex. And I don't know that there's like an evidence-based way for us to evaluate all of the possible combinations of risks in all of the different rules. So I'm not particularly inclined to put a rule like that into the, but I definitely want to hear what other people think about it.
This is Lynette, and I support Kelsey's assertion. I think that our rules are already pretty complicated, and I don't see the benefit in adding additional complication.
This is Bob. Sammy, was your intent to have the board go through this list and us check off the pieces that they had already, that they
Well, the board requested the list, and so I gave them the list as is.
So does the board want to go through the list and clean it up or leave it as is?
I think that maybe the board thought there were more things on the list that they hadn't done, but in reality, they had done most of what they had set out to do, which was kind of why I was trying to show the list as is, that they had done what they had set out to do over that 3-year period, with the exception of the 2 already mentioned. So, good job, board.
And so for clarity, the 2 that we're talking about are clarifications around peer review and specifically what the entity is and what that means, and the non-reassuring fetal surveillance.
Yes, I was on mute. Yes.
Does anyone else have anything that they want to change about the rules?
This is one, I'm looking at the list and trying to understand how long it is. Under legislative changes and under communication and outreach, all that is on that list. Is that correct? Or are those different things?
Sammy?
So there's kind of 3 pieces to the list. One, the first one is rulemaking items. The second one is communication things you guys have talked about doing in the past, and then legislative changes that you've talked about having done in the past. So they're all kind of on this rollout list or parking lot. And like I added, which one did I add here? Oh, I actually didn't even add it. The one about the quick study review guide, like Washington. But so if we change some rules, then I'll go back and do that and we can mark it off the list.
So I want to clarify. I thought when we had the conversation about TXA or tranexamic acid that maybe it wasn't a rule change or a legislative change, that it was indeed just clarifying in the rule that it's already, because we have anti-hemorrhagics already in our rule. Do we just need to add it and it be a rule change, or do we need to go back and do that through the legislature?
That's a good question. I don't know. I'd have to review it further.
Lynette, this is Meredith Mance. I had that understanding as well, that I thought that was an easier one to approach because we already have anti-hemorrhagics in legislation.
Yeah, that was my understanding as well, was that when we were talking about it, we thought we could add TXA, but tributaline wasn't an option because it's a different class, and so we would have in the statute for that.
Then we can add that to the rulemaking, and if, we'll run it by Heather and all of those things and make sure it's legitimate. But yeah, we can do that. I added it on the list.
Okay. Any other questions on that?
So we
No?
now have 3 things. We want to add TXA if we can, clarify peer review entity, and clarify non-reassuring fetal surveillance.
Yes. So moving forward, down to the issue statement, there's kind of 2 or 3 areas I need for you guys to give me some answers on. So in the past, you guys have done rulemaking where the board acts as the experts and does the preliminary review of the rule, preliminary RAC comes around and meets. That's one way of doing it. Or you can do where a RAC meets first, does the preliminary rule, and the board reviews it after. So you just need to know how, if you guys want to move forward the way you've normally done it, if you want to do it a different way. The way I've written it here in the schedule is how you've done it in the past, where you act as the expert, you write the rule how you guys want it, and then the RAC weighs in on how it's reviewed, and then the board weighs back in on what the RAC says. Which would mean adding more time to some of your monthly meetings to just do rulemaking like we had done before. Does that make sense?
Yeah, it seems to me like the fetal surveillance piece and adding TXA would be pretty straightforward rules that we could draft. I think I have concerns about us trying to redraft the peer review entity without getting some kind of input first, because the reason it is the way it is because we didn't have a better way to say it last time. So unless anyone has brilliant new ideas about the peer review entity part, I wonder if we shouldn't do a RAC sooner.
Well,
Like maybe have one deliberation session and then move it to a RAC.
Yeah, you guys could work on the two that you think you can handle yourselves, and then we would just take all three and move them to the RAC.
Can I ask a question? This is I know that this conversation has happened with me in several settings. So I just want to, in this group, what is the intent of that entity statement for the peer review?
Yeah, the intent was so that peer review is not just a midwife talking to midwife friends about a thing that happened, but it's some kind of formal or structured part of like quality improvement, so that there is like some assurance of critical thinking and feedback to improve client care.
So in other professions, is there an approval process for that? Like, for example, in Washington, that entity has to be a QMP, a state qualified QMP organization. And so there's a review that happens at the state level. I don't know that we want to necessarily do that, but I guess that's the question. Do we want to do that? Or is it something like it's going to be an OMC qualified peer review? Or is it, who's going to be the body that's going to review whether or not it meets the definition of entity? And
that's where we were at before, is that those exact two questions. One, the board didn't want to do an approval process. I'm not sure there's authority for it, and the time that it would take maybe more than expected. And two, we didn't want to say, oh, it only can be OMC, that maybe it can be 5 midwives who live in Josephine County, and they can be an entity. So it was trying to be broad enough, but also structured enough that it's not just on a whim, anybody willy-nilly. So, but that's exactly the questions we had before, and this is what we came up with.
So it sounds like we need to provide some more structure.
Maybe even we can write examples in rules, like narrative examples that might be helpful. We've done that in your continuing education rule. There's a narrative example of something that might be helpful for licensees.
But I think, Kelsey, was it your recommendation that that specific rule, some sort of, vetting process, that go, before we take a look at it, that go to a RAC to get some input and feedback and information? Was that what you were proposing, to be clear, and then we would take a look at it?
Yeah, I don't know that it needs to necessarily go to a rack first. I just feel like we wrote it the best that we could given all of the complexity, and I don't know that we could do better now. I mean, we could try if anyone has ideas specifically on how to make that rule more clear. I'm willing for us to take, a try at it first. I just feel a little stuck about it, but maybe that's just me.
And even if the board doesn't make any changes in their initial review, we can still send it to the RAC in its original form. And they can make their comments and then it'll come back to the board to approve it for proposed. So it still kind of works the same way. And maybe, like I said, having an example in the rule saying this is what an entity can also be. It's not just OMC. It can also be 5 people in a county. You know what I mean? So sometimes giving them an example of what that looks like is sometimes helpful. But those are things we can talk about.
I'm sorry, this is Lynette again, and I'm just unclear as to how 5 people in a county is different than willy-nilly, which is the word that Kelsey used. 5 people getting together with their friends willy-nilly. To me, that sounds like the same thing. Like I could say, I live in Washington County and I have 5 friends that also live in Washington County and are midwives. And how is that different?
I don't know that it is.
I think that's what we need to kind of assess first is what is it that we're looking for? What makes it not feel arbitrary in terms of a gathering? Are we wanting to clarify that it's 5 midwives outside your practice? Is it 5 midwives, that have one of which has at least X amount of experience? Like, what are we really trying to get at that makes this feel more comfortable or makes this feel more like an organizational intention than 5 midwives getting together with their friends or whatever?
Yeah, I think that part of it, the way that we have it currently is that it talks about how the entity through which the peer review occurs must be an entity that reviews the quality of professional care provided by the LDM. So like the group has to have a purpose, and part of that purpose is to review the care. And we used entity to make it a little more formal than just getting together with your friends. But I agree. It is ambiguous still.
And maybe another requirement is that the organization meets regularly, like so that it's not just today I've decided to make this group of people.
I'm typing this. I'm not ignoring you guys, just so you know.
I mean, to me, this is Meredith Klein. I think that the most important part is that people are reviewing with, somebody that's not in their own practice. When I worked at a birth center, it was like we would sort of peer review together, but we were going to birth together anyway. So it became more like just a report of what was happening and less of like a critical review. I mean, unless there was, a problem, but a critical review of the case. And I don't know that you can sort of legislate that, like you can control that people, get together. Like we get together in our region and there's more than 5 people there usually. And I don't know what kind of framework would like encourage people to really be, encourage that kind of critical analysis of people's charts, as opposed to just like reporting, I had this many births and this many transports and, this is what I did. And a lot of times there's not that much discussion. And I don't know that naming it an entity would change that. Or that we can really like control what people are going to do in peer review, other than that there's like a diversity of practices there.
This is a little bit what I was meaning about how I felt like the board is stuck about the language, and so I don't know how helpful us trying to come up with a new draft would be. But I don't know. We don't really need to be like deliberating the actual rule today. It sounds pretty clear that this is a rule that we do want to address, I think. But just, you know, if we're gonna be deliberating about rules our next board meeting, maybe if we can do some thinking about how to write this in a way that makes sense and gets at what we want, we can bring it to the next board meeting.
So the March meeting, I would bring a draft of these rules for you guys to start to review and hopefully come up with a proposal for the rec. Yeah. Okay. So the next item is the Heather or the House Bill 2993 requirements for considering identifying interests of communities likely to be affected by a rule change. So looks like we have 3 different rules. 2, I believe, are under practice standards, and then 1 would be under legend, drugs, and devices. So in considering each of them differently, I'm not sure they'll be different communities, but just to think about it. Who does this rule affect? Just generally, I think, is the first question. And it affects consumers of midwifery and the midwives. That would be like the normal. Yes. I assume you agree with me on that.
Yes, it seems like these rules that we're considering changing would affect our midwife licensees and consumers.
So those are our typical kind of people. It could affect, I suppose, the medical community, maybe OHP, stuff like that. Things that we would consider at any rulemaking. But the bigger question is, who have we not thought about, and who do we need to think about now? So considering additional groups unified by common characteristics. So Black communities, Indigenous communities, people of color, are there groups or communities like that that we will be affected by these rule changes?
This is Lynette, and I would say yes, definitely. Black people, BIPOC people, and I would even include rural people as a separate group, both consumers and midwives rurally.
Okay.
And I wonder if it would affect low-income people in terms of like OHP membership.
I was gonna say that too. I was trying to think. I mean, it shouldn't, but maybe we should consider if it would, people who are using Oregon Health Plan or Medicare, Medicaid.
Okay, so I have those. I have Black communities, Indigenous communities, people of color, low income, and rural communities on the list. And there are other ones that, and of course, these are, you can look way outside of the things that I'm, So social, characteristic, historical, economic, political. We talked about geographic, employment or business characteristics. I don't know if any of those would fit other than the geographic one. And the economic one, which is similar to low income, and seeing what we can do through OHP.
I think many of our licensees are small business owners specifically, so not just like midwives who are employees of birth centers, but those that own their own small business. It'd be important to be represented.
Okay, so adding midwives that own small businesses. And are there other areas that we should consider that we're not thinking of that we wouldn't traditionally use for rulemaking? I can't think of any, but this is new, so. And I suppose if we think of one before I mean, we could always revisit this at the next meeting if we, re-go over it and see if there was more things we came up with, since we won't be calling her back until after the next meeting. So we have that to kind of carry us forward.
And can I clarify that the people on the rack can potentially represent multiple communities? Like one of the midwife members could also be BIPOC, and like another of the midwife members could also be, small business owner, and that they can represent multiple communities at once.
Yeah, I don't think the law precludes that. And I think that would probably be fine. Based on Heather's smile, I'm going to go with yes. Okay, let's see what's next here. So who can I contact about these, about getting I mean, we've done this before, right? And I've done hundreds of rules advisory committees among hundreds of many professions, and they're hard to get people on them, hard to nail any single person down, let alone a community of people. So any information you can give me on who to contact, direct contacts would be extremely helpful. If you don't have it here today, you can always email it to me later. But if you have specific groups that may be interested, this would be a good time to kind of throw out some people, names, communities, groups.
I think that reaching out to Oregon Midwifery Council might help find some of the, at least, midwife members.
Okay, I will reach out to OMC. Is there any one person that kind of oversees or kind of is the leader of any specific organization besides OMC that kind of leads the charge for any community group?
What about OABC, which is the birth center organization?
And I also work with Public Health and the Birthing Center Rules Advisory Committee, Melanie. I'm going to find out what she's, because likely we'll have some of the same communities interested. So I'm going to reach out to her and kind of see if we can compare notes and see what she, because she's actually doing this right now and we'll be doing it in the future. So I'm going to see what how she's going about this. So that'll be helpful. And I can report that back at the March meeting.
Sammy, this is Bob.
Yes, Bob.
For the Oregon Health Authority, there's the Office of Equity and Inclusion. They may have some guidance.
Yes,
and
I will
information for you.
contact them. Thank you, Bob. And I haven't, so my apologies, I've been out for 5 weeks, so I'm not really up on this a lot. So I will spend the next month getting very well versed in this and having some better ideas, and I will report what I've found at the March meeting. So I apologize for not being totally prepared. So moving forward, let's see, identify what persons and racial groups are impacted. So I think we've pretty well went over all of this. If I have more questions or need more information, I'll ask at the March meeting. I'll either put it on if I need more information or if I want to report out what I have gathered since then. Is everybody okay with that?
Sounds good.
Okay, so the last piece would be to, oh, I guess the other piece is, do we want to also make sure that we get representation of the regular people we would normally in? Usually it's like 3 midwives, 3 LDMs, 2 CNMs, 1 obstetrician, 1 pediatrician, 2 consumers. That's kind of a smattering of what we've had traditionally, which again is often hard to get.
I 2 nurse midwives is maybe more than we need. I think 1 nurse midwife would be sufficient.
Okay.
And I think we could broaden the obstetrician. I think it could be any provider that practices maybe in a hospital-based setting or something like that. I don't know that it necessarily has to be an obstetrician, especially when specializing in maternal fetal medicine.
Right, like there's plenty of family practice doctors that do obstetrics. I agree, Lynette.
Does there have to be 10 individuals, or that's just like a general recommendation?
Just a general number.
Okay.
I would propose the same thing for the pediatric provider. I don't think it necessarily needs to be someone specializing in neonatology. It could potentially be a naturopathic doctor who treats newborns and babies.
I agree with that. I think it could also be like an FNP would fill that role.
Okay. And then we always try for a consumer, at least 1. Not that I get them, but I do try. Okay. Okay, so now, hold on.
Since we're specifically talking about the peer review and the entity piece, do we want someone from OMC specifically on this rack as like a representative of one of the quality improvement organizations? I saw Lynette shake your head a little bit.
I don't feel like that's necessary, especially if we're trying to get ideas from outside the box. And I feel like there's a good chance that of the direct entry midwives, there's probably at least one of them that also meets the qualification of being a member of OMC, but
Okay, and then the next, so the schedule that I drafted up had you guys deliberating in March and April. It sounds like you can probably just deliberate in March. And then I don't have a rules advisory committee meeting until June. I think I could probably bump that to sooner. So I would tweak this a bit and bring it back to you guys. Are you okay with
That
that?
sounds good.
Okay, so I would just tweak this a little bit, and then in hopes that we could have maybe a permanent rule by August, September, would be my thinking. If we're just gonna do one board meeting and then go right to the RAC. With the caveat that obviously if we can't find all the people we need, it could extend time out some, but let's hope that doesn't happen. So that is really all I have. If you guys want to make a motion to well, not really approving the schedule. Well, let's see. Recommend the communities and groups that you gave me for the RAC, and that I'll bring a revised schedule to the next meeting. And the 3 topics for rulemaking.
Sammy, I don't know that we need a vote on that necessarily. If we do, it might make sense to do it next time once they consider more. That way they don't need to go back and amend their vote. But
Perfect.
That's just a suggestion.
I love that. Perfect. Thank you, Heather. Okay, that's all I have. Good job. Thanks, guys.
Thank you, Sammy. So this is Bob again. Next item is public and interested parties feedback. Is anybody on the phone?
Yes, this is Silka Akerson from the Oregon Midwifery Council.
Hi, Silka. Good morning. Hey, did you send April an email? Let her know that you were on the...
No, I didn't realize that I needed to do that.
Yes, if you would. Do you have her email address in the notification?
I think I have. I can find your email address.
No problem. When we read into it, Kelsey will provide it again.
Yeah, can someone say her email right now?
We will shortly.
Are you wanting me to read it?
You have to read us into public and interested parties.
Oh. Oh, here we go. This time, the Board of Direct Entry Midwifery will hear public and interested parties' feedback. Members of the public, please wait until you have been recognized. Once recognized, please state your name and affiliation to the board for the record.
Silka, April's email address is april.fleming@dhsoha.state.or.us.
Thank you.
Thank you. Is there something, did you want to speak to the board this morning?
Yes. I do. This is Silke Akerson from the Oregon Midwifery Council. Thank you for this opportunity to give public comment. I have a number of comments today about things that the board has discussed and a few other things. Kind of moving backwards through the discussion. The first thing I wanted to talk about is the new statute to make sure that there is representation when there are RACs or other need for public input. And I think that getting input from Black, Indigenous, Latine, Asian, Middle Eastern, South Pacific Islander communities is one of the most important priorities in that bill. And two organizations that weren't mentioned that I think the board should be sending public notice to are Forward Together, which has been doing a lot of work about the needs of families of color around pregnancy, birth, and postpartum and access to care. And then the other one is the Health Initiative, which specifically works with African American families around pregnancy, birth, and postpartum. So I think those would be two important organizations for the board to be sending public notice to. And, maybe not just sending them randomly, but figuring out who in the organization is a good point person. The other thing I wanted to say about that is I continue to be concerned about the idea that Board of Direct Entry Midwifery, RACs, and other public comment need to specifically solicit input from obstetricians and nurse midwives who are hospital-based. That never once in my 22 years has there been rulemaking for nurses or for physicians that seeks input from midwives or seeks input from chiropractors or naturopaths or physical therapists. And I think we are continuing to uphold a double standard when we continuously prioritize input. I think that representation that we have on the board is absolutely adequate to make sure that those interests are part of the decision making. I did want to bring up again that it's something that I brought up quite a few times, which is about public notice for these meetings. It's very, very difficult for members of the public, especially people who are working, to attend the public portions of this meeting when no times are given for the public portions. And I request, as I've requested many times before, that either the executive sessions be grouped at the end or an approximate time be given of when the public session will commence. Because it means that instead of knowing that I'm going to be on this meeting for an hour or two and being able to schedule other appointments, the only reason I'm able to be at these meetings is because this is a dedicated part of my job, and I'm able to, sit here waiting to know whether the executive session is going to be 5 minutes or 2 hours, whereas most other people can't set aside that amount of time. And I think it's a major access issue to these actually being public meetings. Okay, so public input, meeting times. The third thing that I wanted to talk about was the continued issue with the expenses of the board being greater than the income of the board. And I think this is something where the members of the board need to check in with the legislature at some point to try to figure out a lasting solution to this. I think that there are legislators on the House Health Committee, which has been the committee that's been most involved with the Licensed Direct Entry Midwifery Board for many years, who would really want to know that this is a continued issue and that there isn't a current solution or a proposal for a solution, because while the intention was to keep the licensing costs low, I don't think the intention was just for the cost to accrue over time. So I think there's an obligation of the board and the health licensing office to the legislature to make sure that they stay informed about this. My third comment, and then my fourth set of comments are about the potential rule changes. And there are a couple of problems I see in the current rules that I'm hoping that eventually the board will address. The first relates to something that was brought up around non-reassuring fetal surveillance. And there have been some cases around intrauterine growth restriction, IUGR, that have come up recently. And I was just assumed that the rule covered IUGR, and I read through the whole rule, and I don't see that it does. And I know that there had been some discussion about just saying that non-reassuring fetal surveillance includes IUGR, but I was looking up the definition of non-reassuring fetal surveillance, and from everything that I found, I don't think that that's applicable. I think if the board wants to address IUGR, it would need to be named on its own. I don't think it fits within the definition of non-reassuring fetal surveillance that I was finding. Secondly, I wanted to restate that the reason why OMC advocated for changes to the peer review rules is that we think it's really, really important for midwives, like all maternity care providers, to be involved in structured quality improvement. And midwifery practices generally are so small, it's very difficult for structured quality improvement to happen at the practice level. And to our knowledge, we are the only kind of larger organization in the state working on quality improvement with community birth midwives in a structured way. And we don't think we should be the only organization. It would be great if there were other organizations as well. But you know, maternity care providers that work in a hospital setting are all involved in formal quality improvement, and the peer review that they do is part of that quality improvement program in their hospital setting. And we want to ensure that midwives who practice in a home birth or a birth center setting are doing some kind of peer review that's related to quality improvement, that has standards, that has, you know, procedures for when specific conventional events happen. And I think that I don't think the rule needs to become much more complex. I actually think it needs to be simplified and made more clear. I think it might seem like a first step might be to look back at the peer review statute and see what kinds of language it has about peer review bodies, because it has a number of has language about peer review bodies in that statute, and also to look at what's been done in other states, like Lynette was referring to Washington, and look at the way that they have referred to organizations that work on quality improvement and quality management. To my knowledge, Oregon doesn't have something like what Lynette was describing in Washington, where there's kind of a definition of a quality management program. At least not that I know of. So yeah, I just think that's an area that needs research and clarification that is simplification, not clarification that creates more confusion. Two other areas in the rule that I think need adaptation. One is the blood pressure cutoffs that require transfer of care. This was a kind of an area of contention during the rulemaking process, and Dr. Wendy Smith has been advocating for a somewhat higher cutoff or more a different way of approaching this, and the idea had been to go with a lower cutoff, a more conservative cutoff. And what I'm seeing in the community in review is that I think this current rule is leading to quite a few unnecessary transfers, unnecessary inductions, and this is especially concerning at a time when we're having pretty limited resource of hospital inductions and maternity care because of staffing shortages in the hospital. So we currently have a situation where someone could have, one blood pressure that's 130 over 88 and another blood pressure that's 132 over 88 or 86. And that could be an indication for transfer of care, even without any labs that are concerning any other signs. And I think that we've set this threshold too low and we're causing harm. It's not that midwives shouldn't be extremely careful about signs that someone could be developing preeclampsia and that there needs to be careful blood pressure monitoring, but too marginally high blood pressures without evidence that these are ongoing or without evidence of other features is not an appropriate cutoff for transfer, and I'm concerned about the harm that the current rule is causing. Then the other piece in the rule that I wanted to bring up that hasn't ever been brought up before to my knowledge is, and I don't know if it's possible to do this in the rule, I'm very curious. So many midwives in the state are preceptors or clinical supervisors to student midwives, and we don't have any standard or requirement or safeguards in rule about the conduct of LDMs as preceptors or clinical supervisors to students. And we've occasionally had situations where an LVM has acted in a significantly not professional or harmful manner towards a student, but there is no recourse for that, especially if the student is in the PEP process and is not in a midwifery school. Sometimes if they're in the midwifery school, the school has a process, but NARM, which kind of evaluates midwifery education and whether someone is qualified to sit for the exam, doesn't have a process for investigating complaints preceptors unless it's extremely egregious, and there is no other body doing this. So there's kind of no place that a student can have recourse if an LDM who is a preschool supervisor behaves in like an egregious non-professional manner. So I don't know if that's something that is appropriate for the rule to address or whether it even can address it, because the student preceptor relationship isn't outlined in the LDM statute, but I think it's something that the board should be at least aware of and have a discussion about. And then the final thing, which is separate from the rules, but I just wanted to provide clarity on Oregon Midwifery Council's position on, is there's been discussion over time about the disciplinary actions on the Board of Direct Entry Midwifery website, and discussions about whether final orders should be publicly available or information about disciplinary investigations when they're in process should be available. And our input is that we think that final orders, once a case is concluded, should be publicly available on the website, but that investigations, disciplinary actions when they are in process would not be publicly available, because we think that it can be misleading to see what someone is accused of before it's settled, whether that was in fact what happened or not. So those are all of my comments. I know that was a lot of comments, so if there are questions about any of them, please feel free to ask.
Thank you, Silko. And we will. You've sat through these meetings before. If the board members have questions, they should go through Sammy. And we'll filter them to you. Not filter them, but we'll get them to you to try to get answers and get answers for the board. And if you have additional questions or concerns, you're also more than welcome to.
Can you clarify that? Because my experience in my many years of coming to board meetings is that board members in meetings have been able to ask me questions, and other members of the public giving public comment direct.
Oh yeah, they can.
Directly ask us questions.
No, they can if they don't have any right now. And if something.
Oh, you mean if they have some later?
Yeah, if something comes to mind, they can reach out to Sammy and we'll get it out to you.
Yeah, great.
Okay.
Yeah, I'd like to respond to Silka a few different points, if I might. Thank you for the recommendations for the Forward Together and Healthy Birth initiative. I'm really looking forward to them potentially being involved in our RACs. I agree that it's hard for the public to come to meetings when things aren't clear from the agendas, but I think this time our agenda did have times on it. They were just wrong. I mean, not wrong, but approximate, and not very close today. So that is one change that it looks like we have implemented. So thank you to the office for putting some times on the agenda. I'm a little confused about what you're saying about the hypertension cutoffs, because my understanding is that it's 140/90. And so the numbers that you were saying of like 138 over or 132/88.
Sorry, I just said it wrong.
Okay.
I just messed up in my example.
Right. Yeah, and then the rule is that has to happen twice, at least 4 hours apart.
But twice, at least 4 hours apart, could be at one appointment and an appointment 2 weeks later.
Yes, yeah. No, but I appreciate your concern, especially with the hospital capacity, and I think that it's reasonable for us to talk as a board if there's any other adjustments that we think we need to make because of COVID. But that does make sense to look into to me. I think that was all my thoughts. Any other?
Yeah, I was wondering, this is Meredith Klein, what it was before. I thought that it was 140/90 before prenatally, and then in birth, it, labor and birth, we had a higher threshold, and that this new rule just brought it down to 140/90, in any part of care. Does anybody remember? I mean, I could look back at the old rules, but.
Yeah, Meredith, I think that that's my understanding as well. I think that the concern is just that, like, with hospital capacity, it's hard to transfer people for something, especially when it's borderline like that, especially since then sometimes the hospital will just send them back to you.
So it's just a question about context right now. Not about changing.
My comment was not just about context right now.
Okay.
I don't remember what the former rule had been, but there was a long discussion about the cutoff with Wendy Smith advocating for a higher cutoff in the absence of any other signs or symptoms. or at least more, a different cutoff, because they're, I view it somewhat like gestational diabetes. 1 or 2 higher blood pressures that are in the marginally high range are not a risk. Continuous ongoing blood pressure is a risk, or blood pressure with other features. They're like 2 isolated blood pressures that are marginally high may or may not be an appropriate time for a transfer.
Sure. So this is Lynette, and I propose that we ask Sammy to add that on our list, and we can bring it up again at that March meeting with hopefully Wendy present to remind us what her thoughts were.
Yeah, even maybe Sammy, could you message Wendy and let her know that that's something that we're considering so that she could come prepared with?
Yes.
Thanks.
Okay, this is Bob. Was there anything else? Kelsey?
I don't have anything else. So our next agenda item is another executive session.
Yes, correct.
All right. The Board of Direct Entry Midwifery will now be in executive session pursuant to ORS 192.6602F and ORS 676.595 for the purpose of considering information exempt from public disclosure at 9:53 a.m. on February 10th, 2022. Representatives of the news media shall be allowed to attend the executive session by conference call and will be provided further call-in instructions shortly. The public phone line will be muted for the duration of executive session. Are there any representatives of the news media?
Okay. Stand by, please.